Welcome to today's healthcare provider program brought to you by Living Beyond Breast Cancer and the Breast Cancer Resource Center. At this time, all participants are in listen-only mode and cameras are disabled. We are recording the session and we'll post it on lbbc.org and bcrc.org about a week after the program. We will notify you via email when the recording is available. Please use the chat feature to communicate with any technical issues or questions for the moderators. All questions for the speaker should be submitted through Q&A feature. You'll see the chat icon at the bottom of your screen. The Q&A feature is also located at the bottom of your screen. Please submit questions through the Q&A at any time. We will respond to as many questions as possible after the presentation. For participants who would like to use closed captioning, you can select this feature by clicking the up arrow button next to closed caption on the bottom of your screen. Then click show subtitles to start displaying the captions. So hello, everyone, and welcome to today's healthcare provider program, the role of spirituality in cancer care, a framework for providers. We're glad you could join us. My name is Elaine Gonzalez. I'm the community educator at the Breast Cancer Resource Center, or BCRC. I'm pleased to serve as your moderator today. The Breast Cancer Resource Center is a community-based nonprofit serving Central Texans impacted by breast cancer since 1995, strengthened by our mission to empower those affected by breast cancer with personalized support and compassion. And in collaboration with our community partners, BCRC envisions a future where no one faces breast cancer alone. BCRC offers individualized patient-centered care from diagnosis through treatment and into survivorship. Through its two pillars of support, guidance and education, BCRC's certified patient navigators, whom are all breast cancer survivors themselves, empower those touched by breast cancer to become active and knowledgeable in participants in their healthcare journey. We will also be joined by Stephanie Washburn with Living Beyond Breast Cancer, LBBC, who will serve as the Q&A moderator. Living Beyond Breast Cancer is a national nonprofit organization that understands there is more than one way to have breast cancer. To fulfill their mission of providing trusted information and a community of support, Living Beyond Breast Cancer offers psychosocial, practical, and evidence-based content that is meaningful to those newly diagnosed in treatment, post-treatment, and living with metastatic disease. Living Beyond Breast Cancer also offers valuable programs and resources for healthcare providers. This program is provided as part of a cooperative agreement awarded by the Centers for Disease Control and Prevention to expand our programs for young women. The purpose is to increase the availability of supportive services for young breast cancer survivors, young women with metastatic breast cancer, and their caregivers and family. This CDC funding continues today. We will be emailing you a link to an evaluation after the program. Your feedback is very important to us in planning future healthcare provider webinars, and we appreciate you taking the time to share your input. If you've registered to receive nursing contact hours or social work CEs for today's program, you are required to participate in the entire live webinar and complete the evaluation, which you will receive today. By October 7th, you will then be emailed your continuing education certificate by November 4th. Certificates of participation will also be available upon request through the evaluation process for providers from other disciplines. This activity has been approved by the Ohio Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation for 1 contact hour, and by the National Association of Social Workers for 1 CE. I would also like to note that no one with the ability to control content of this activity has a relevant financial relationship with an ineligible company. Our objectives for today's program are to help providers understand the role of spirituality in coping with breast cancer, discuss patients' diverse perspectives on spirituality and its meaning in their breast cancer experience, highlight the connection between spirituality and healthcare, explain patient-centered spiritual care, provide a framework of how to talk with patients about spirituality and connect them to resources for spiritual care, address the role of unique spirituality practices that impact treatment. It's now my pleasure to introduce Dr. Tracy Balboni. Dr. Balboni holds degrees from Stanford University, Harvard Medical School, and the Harvard School of Public Health. She is board certified in both radiation oncology and palliative medicine. Dr. Balboni currently serves as professor of radiation oncology at Harvard Medical School and as a program director of the Harvard Radiation Oncology Program. She also co-leads the initiative on health, religion, and spirituality at Harvard. Dr. Balboni, we're happy to have you with us today. Please join us on screen and share your presentation. I will now turn things over to you.
Thank you, Elaine. And it's just such a pleasure to be here with all of you today. Thank you to the Breast Cancer Resource Center and Living Beyond Breast Cancer, those communities that are supporting this event today, where we can discuss the role of spirituality in cancer care. And we hope help you all to have a framework for how you can support the spiritual health of your patients. The way we're going to be doing that today is in two parts. First, I'm going to be providing us with a context, the context of how we practice care today, and in particular, how that relates to the relationship between spirituality and the practice of medicine. And I'll be doing that by describing both historical and empirical, the historical and empirical context. And with that context, we'll then move on to considering guidelines for spiritual care provision, as well as using those guidelines to begin to develop a framework for how we can approach spiritual care of our patients. From there, I'll pass it on to my friend, the Reverend Dr. Maiko, who will be providing us with key domains of spirituality for assessment, ways in which spirituality can function in the setting of cancer, and then helping us to understand and interface with the work of chaplaincy. So I'm beginning with the historical background. And one important first sort of caveat to note is that we function, many of us function within what we might term Western biomedicine. It is a specific healing tradition. It's important to note that there are other healing traditions that have a much more integrated conception of body and spirit. And I'm just providing you with one example here. This is that of Chinese medicine and the acupuncture meridians that are used as part of Chinese medicine. It has a much more integrated conception of body and spirit. In contrast, Western medicine, Western biomedicine, particularly since the time of the Enlightenment, has been very much framed by a focus on the body and a relative neglect of other aspects of what it means to be human or the spirit. And that really only has been about since the Enlightenment to the present day. It's important to note that prior to that, spirituality and the practice of medicine was very much integrated within sort of the origins of Western biomedicine. So, for example, the first hospitals were actually located within spiritual communities. The whole discipline of nursing very much has arisen from those with strong, coming from a strong spiritual conviction and understanding of the practice of nursing. But speaking, I want to help us to understand these Enlightenment principles, as much as it might seem a little bit sort of not relevant to our everyday practice. I believe it's sort of the water around the fish of how we practice medicine day to day. And that is that since the Enlightenment, there has been the growth of the philosophies of materialism, which is the way that we understand ourselves and truths about our world is through the material world solely. And its primary tool is reductionism, or the breaking of the material down to its component parts in order to understand it thoroughly. So, for example, my talk today would be best understood by simply breaking it down into its component parts, down to the very neurons firing as I'm speaking and as you're listening here to me today. And you can imagine that with the growth of materialism and reductionism, the empirical method has become the primary source of truth, finding truth for humanity. And I just want to highlight that this has been a wonderful gift, and it is a wonderful tool. It's a wonderful tool in that it's helped us to understand material processes that are behind suffering, that are behind illness, and allowed us to begin to cure illnesses, to cure disease in beautiful ways. And with that ability, of course, medicine has grown increasingly in its material focus and care. But I believe that it oftentimes that can be to the neglect of other aspects of what it means to be human. And that issue was very much illustrated by this Enlightenment painter. This is William Blake in his painting entitled Newton, painted during the Enlightenment. And there's a commentary on this very issue within this painting. So I just want you to look at it with me. So first, of course, we know that this is the figure Newton, who's very much one who has helped us to understand the material world. And what is this figure like? This figure is very muscular, young and strong, and again, sort of highlighting the wonderful strengths that come from the study of the material world. And what is he looking at? He's looking at geometric forms on a scroll beneath, and there's all this wonderful light passing between his eyes and the geometric forms below. But the commentary here that's being made by this painter is notable in the fact that all around the figure, in fact, the very seat that this figure is seated upon, are myriad forms that are outside that fixed gaze, just helping us to see that though there is much strength and beauty and light that comes from study of the material world, we need to realize that there are parts of our reality that make us human that extend far beyond that fixed gaze. And I just want to, with two more paintings, illustrate to you how that can create a shift within medicine that's sort of zeroing in on the material. So these are also two Enlightenment paintings. This first one is by Sir Luke Fildus, entitled The Doctor. Fildus is actually in this painting. If you see in the background, the very sort of dark figure is Fildus himself, the artist. And this is the artist with his hand on his wife who's crying on the table. And what is this? This is the image of his dying son. So this artist depicted such a tragic moment in his life, in his family's life, and that is the death of his child. And yet he depicted it, and he depicted it with beauty and with even a degree of hope. And where did that come from? And you can see it in the interaction between this physician and this young boy. We see tremendous light and warmth and love and care that's brought by this physician. We see maybe on the table that there were some medicines that were used that attempted to save this young boy's life that are no longer being used, and yet the physician is still present. There is connection, and because of that connection, this becomes a poignant and even hopeful moment, as depicted in this painting beautifully. Now let's contrast it with this second painting, which I would say now comes with more and more of a material focus and care. The setting is very different. Here we are in the affluent doctor's office, not in the home. Here the physician is not peering at the patient. The physician is actually peering at the technology of that day, including perhaps a medical book and then the medical technologies on the table. And where is the connection with the patient? There is no connection with the patient. In fact, the patient is very much isolated, and we know that this is a poignant moment in this painting because of its title. The title is The Sentence of Death. This young man has just received news that he has a terminal illness. And so I'm just making this point, illustrating it with artistry, that this kind of, even, philosophy kind of seems like it's up in the sky and isn't relevant to our everyday. But I would say that these issues impact us. They're all around us. And this sort of separation of the spiritual from the material impacts patients, us as caregivers of patients, and even medical institutions. And I just want to make this point by sharing a story of one of my patients. I'll call her Kate. This is not her image, but it's just an image from the internet that reminds me of my patient, Kate. She had a metastatic cancer and was in and out of the hospital many times as her disease advanced. And one of the times she came to the hospital, this is what she said to me. She said, every time I walk into this place, it feels like all my energy has been sapped out of me. I can almost hear this place telling me that all I am is a body full of tumors that are killing me. She was expressing to me how when she comes into the hospital, everyone around her is just looking at her material body. And it makes her feel like all she is a body full of tumors that are killing her. And they're not seeing the rest of her. And I would say that goes beyond patient experience. It also influences us as caregivers. This is Paul Kalanithi, a neurosurgeon and author who wrote this book, When Breath Becomes Air. This is a beautiful and just heartbreaking also story of this young man's life in which he is training as a neurosurgeon, and then it pivots on his diagnosis of an advanced lung cancer, and then takes you through his experience as he struggles as a patient, and ultimately to the time of his death. And in this book, as when he's describing his training as a neurosurgeon, he describes how the experience of training was often dehumanizing to him. And I'll just share with you one excerpt here. He writes, while he was training as a neurosurgeon, some days this is how it felt when I was in the hospital, trapped in an endless jungle summer, wet with sweat, the rain of tears of the families of the dying pouring down. I was losing sight of the singular importance of human relationships, not between patients and their families, but between doctor and patient. And you can almost imagine my patient Kate and Paul in the same hospital together, that patients like Kate and physicians and nurses and social workers and other caregivers like Paul are in the hospital together, and yet they are separated by this neglect of the larger aspects of what it means to be a human, whether as an individual facing an illness or as a caregiver of those with illness. So with that in mind, with that context in mind, let's consider how we can be reintegrating spirituality into the practice of medicine, and in particular into cancer care. And we're going to start by providing you with research that illustrates how spirituality interfaces with the cancer experience. And I'm going to be doing that by posing you questions, and then answering those questions with sort of examples from a large body of research literature. So the first question is spirituality important in serious illness, and how? So this is a national study of cancer survivors, over 8,400 of them, in which they were asked, my faith or spirituality has helped me through my cancer experience, from not at all to very much. And you can see that about 70% of the sample indicated that spirituality was helping them through their cancer experience. And this is particularly the case for racial and ethnic minorities within the United States. This is a smaller study, but provides us with a bit of an answer to the question of how is spirituality important in the context of a serious illness like cancer. So this is a study of 75 patients receiving palliative radiotherapy for their cancers at 4 Boston centers. 78% indicated that religion or spirituality was important to their advanced cancer experience. And when asked how has religion or spirituality been important, their answers were open-ended answers were qualitatively analyzed. And the qualitative analysis showed a variety of ways or themes which were noted by these patients. So the first theme was that of coping through one's spirituality. So for example, this patient saying, if it weren't for my faith, I don't know I would have kept my equilibrium through this process. So coping through one's spiritual beliefs is a very common way in which spirituality interfaces with an illness experience, like experiencing cancer. Spiritual practices like prayer, mentioned by this patient, are also quite common. Another theme was that of spiritual beliefs, or beliefs that are providing a framework for understanding one's illness. This patient is a great example of this. This person said, based on my religious beliefs, I think I was given a certain number of days on this earth from day one, and I don't think that changes with my diagnosis. Another common theme was that of spiritual transformation, or a change in one's spiritual experiences or beliefs as a result of the illness experience. And then finally, another common theme was that of the importance of spiritual communities, oftentimes these communities providing key support for patients and families. So we see that spirituality is important to most patients. It's functioning in multiple ways. Another question is, what is the relationship of patient spirituality to quality of life and illness? That's addressed by this study, a study of over 1,600 cancer patients where spirituality was measured with a validated scale, the FAAHPM, and found to be an independent predictor of patient quality of life, even after controlling for other key predictors of quality of life. In another study, this is a study of over 1,800 patients with a variety of types of serious illness, not just cancer, other serious illnesses as well, in which they were simply asked, what is most important to your well-being at the end of life? And they were provided 44 possible attributes. The top 9 of those 44 were then ranked, and I'll just highlight for you here that the top 2 for patients. And those top 2 factors that they viewed were most important to their well-being at the end of life was being free from pain and being at peace with God. And in fact, the authors of this paper noted that these statistically tied for first. So clearly a spiritual construct, being at peace with God, rising to the fore is one of the most important issues to patients as far as their well-being at the end of life. So a third question is, does spirituality play a role in medical decision-making? And this is a study of 100 patients with advanced lung cancers, their family caregivers, and then medical oncologists who care for advanced lung cancer patients. Each of these groups were asked to rank 7 factors important to the patient in making treatment decisions. These were the 7 factors. All 3 groups agreed that the ability of the treatment to cure the disease was the number one factor that would influence patients. But then second for patients and families, and last for physicians, was patients' faith in God. So illustrating how a patient's faith is in their minds important to their medical decision-making. The family understands that that is the case, and yet physicians aren't necessarily recognizing that that's the case. But does that role of spirituality in medical decision-making actually impact types of decisions made at the end of life? This study would suggest that it does. This is a prospective cohort study of patients with advanced cancers in which at baseline, their religious and spiritual coping, remember in that qualitative analysis I pointed out to you earlier, coping was one of the primary themes that was found when we did that qualitative analysis of how spirituality was functioning within a cancer experience. So spiritual coping was measured with a validated scale and split into high versus low, just based on a median split. And then patients were followed until the end of their lives. And then at this x-axis, we can see aggressive medical interventions in the last week of life. And you can see that patients exhibiting high religious coping at baseline, something went wrong, please try again, received more ventilation, greater resuscitation, and ultimately were more likely to die in an ICU setting, suggesting that spirituality indeed is influencing medical decision-making at the end of life. This, of course, raises, well, how is spirituality interfacing with medical decisions at the end of life? This study explores possible beliefs in end-of-life care, religious or spiritual beliefs that are potentially influencing medical decisions. And this was a study of over 275 advanced cancer patients. 7 religious beliefs in end-of-life care were assessed. And anything in the shades of blue is at least some agreement, some endorsement of the belief by the patient. You can see that these are frequently, many of these are frequently endorsed. So for example, my belief in God relieves me of needing to think about future medical decisions, especially near the end of life. That was around nearly 60% of patients. Or I believe that God could perform a miracle in curing me of my cancer, about 70% of patients. And in fact, 87% of these patients endorsed at least one item, and 62% endorsed 3 or more items, just illustrating how frequent these religious beliefs in end-of-life care can be. So we've seen how spirituality is important in illness. It's functioning in multiple ways. It's influencing patient quality of life. It's also influencing medical decision-making. A next question is, does providing spiritual support, so attention to those factors, does it influence key outcomes in the setting of illnesses like cancer? So as part of a multi-site prospective study of advanced cancer patients that was examining psychosocial and spiritual factors and their relationship to end-of-life outcomes, spiritual care was assessed. It was assessed in 3 separate ways. First, the patient assessed whether they were receiving support of their spiritual needs by the medical team, and that's the entire medical team, doctors, nurses, chaplains, etc. Support of spiritual needs by communities, and receipt of pastoral care visits. Outcomes included quality of life that was assessed by a caregiver present with the patient in the last week of life, and then medical care that was received in the last week of life. So this first set of bar graphs is illustrating to you the quality of life at the end of life results, shown here in the y-axis. And the blue here indicates when spiritual care was present versus orange when spiritual care was absent. The bar graphs all the way over to the right are when spiritual care in any form was present is the blue, and no spiritual care in the orange. And what we can see here is in adjusted analyses, those who reported any form of spiritual care at baseline, so spiritual care is integrated as part of their care, had better quality of life at the end of life as compared to those who reported no spiritual care, suggesting that patients who are receiving spiritual care have better quality of life at the end of life. What about medical care outcomes? So high spiritual support from the medical team was reported by a minority of patients, 26%, but when it was present, patients transitioned to hospice more frequently. They had less aggressive interventions and were less likely to die in the ICU setting. And that impact of medical team spiritual support on end-of-life care was largely seen in those high religious coping patients. Remember, those are the patients who had a greater risk of receiving aggressive care at the end of life. Interestingly, high spiritual support from religious communities was associated with less hospice and greater aggressive interventions and more ICU deaths, and that those findings were more pronounced among our high religious coping patients. One hypothesis is that this may be due to kind of further endorsement or support of those religious beliefs in end-of-life care that I mentioned to you earlier that may be resulting in choices for greater aggressive care. So there's sort of a story unfolding through the research. Spirituality is important within illness. It's functioning in multiple ways. It's influencing quality of life and medical decision-making. Religious beliefs within end-of-life care are common. And it also appears that spiritual care influences patient quality of life, their well-being, as well as their medical decision-making. As a result of this research, this body of research, the National Consensus Project, which is the quality of care setting guideline for palliative care within North America, has set forth spiritual care as one of its 8 domains of care. And it includes this spiritual care framework. First, that there is a generalist specialist model where non-chaplain healthcare workers, most of us, are the spiritual care generalists, and chaplains are our spiritual care specialists. As generalists, our primary role is in spiritual history taking, in asking. And then that spiritual history guides subsequent conversations and referrals to spiritual care professionals. I would also say that that spiritual history says to the patient, I see this aspect of you, and it is okay for you to share about any spiritual needs with me as part of your overall care. So this includes, as far as the generalist role, are doing a screening spiritual history as part of a social history. And I believe this can be readily integrated into our social histories. Here are a few example questions. So for example, do you consider yourself a spiritual or religious person, both or neither? Do you have a faith or spirituality that's important to you? Or what are some primary sources of meaning and hope for you? So for example, sometimes two of these questions work well, particularly to get at the myriad of expressions of spirituality in our patients. For example, asking, do you consider yourself a spiritual or religious person, both or neither? And someone might say both, or another person might say, well, actually, no, I'm not spiritual or religious. And then you can ask, well, what are some primary sources of meaning and hope for you? I think it's important for us to find our own language, what fits with us as far as our practice of patients, but to regularly integrate it into our social histories. And then we apply that information to guide future questions, conversations, either at that time or at the time of future visits. So this is our spiritual care framework. It is centered around doing regular spiritual histories because it opens a door. First and foremost, it implicitly says to the patient, your medical care includes attention to all of you. And it's okay to talk about your spirituality, your core values here. I wish to honor that as part of your care. It also gives you key information about the patient to guide future care. So as far as our next steps, because we're just beginning by opening the door, I do want to turn it over to Reverend Dr. Maiko, and he will take us further into exploring the spirituality of our patients and working with chaplaincy. I believe perhaps Elaine will be, oh, great.
Thank you, Dr. Balboni, for sharing this valuable information with us. It's now my pleasure to introduce Reverend Dr. Saneta Maiko. Dr. Maiko is a faculty member of Indiana University Health's Dan Evans Center for Spiritual and Religious Values. His clinical research investigates the role of spirituality and religion on the emotional and spiritual well-being of outpatient metastatic cancer patients and caregivers. Dr. Maiko, we're so happy to have you with us today. Please join us on screen and share your presentation. I will turn things over to you.
Hello, thank you so much for being here. I'm so grateful for Dr. Balboni for taking us through the process. I appreciate all the things that Dr. Balboni has shared, and clearly speaking from the science world, how important science and spirituality is so much interconnected in some ways of changing patients' and families' lives. I am glad to hear the science that has been done, the research that has been done, showing that even when patients and families deal with those distressing experiences, when they feel that their psychological, emotional, physical, and spiritual is distressed, they're able to turn to cope using spirituality and religion. Cancer, of course, affects families and caregivers, even those who are close, based on the research that we have. It also tells us that when spiritual and religious concerns show up, cancer patients and their families are likely to go back to those moments of asking, what does this mean to me? So when we think of spiritual needs for cancer patients, how do we create opportunities for patients and caregivers so that they can discuss what they wish to discuss? And especially looking at areas of communication skills and creating time for them. Patients also express that they need resources, spiritually driven or religiously driven, that really gives them some affirmation or gives them some value. You are all here because you have a desire to help someone. You are here to help someone going through challenges, especially those who are dealing with breast cancer. Research has also indicated that even those who deal with other illnesses like mental health, they tend to turn to spirituality and religious beliefs in order to cope. So friends, I look at this today as a moment for each one of us, especially most of the nurses and social workers, doctors, all those who are involved in patients' lives, starting to ask ourselves, how do we move from the world of dry medicine to engage a human being who is not only a body, but someone who has a mind and someone who has a soul? Chaplains are professionals who are trained in the healthcare system or in places where patients come to seek services. And chaplains have always been intentional in the way they show up and in the way they work alongside other professionals so that the patient's spiritual core is addressed. How are they trained? The chaplains are trained. They have to have a bachelor's degree. They have to go to a seminary to get a master's degree, maybe a master of divinity or a master of theology or master of philosophy. And after getting that master's degree, then they have to go clinical training, CPE training, clinical pastoral education training, which is intensive. They spend a whole year of residency into that program, and then they have to write papers for competencies so that they can show they are able to understand the struggles of patients and families. That's why they are called specialists in this area. When they become specialists, they know how to listen, they know how to make a reflection of what they have heard, and they also know how to respond. So when is the best time to make a referral of the patient or family to the chaplains? I am glad that Dr. Balboni has given us a story-taking framework, which really everyone should be able to ask. If you are a social worker, nurse, or anyone who works with these patients, you can easily ask, do you consider yourself spiritual, religious, both or neither? They will be able to tell you where they come from. And in that question, it helps you to discern more if they want to ask it deeply. Indiana University Health has been developing a framework called SCI, Spiritual Care Assessment Intervention Framework. In this framework, it has identified 4 dimensions. The first dimension is meaning and purpose. And in meaning and purpose is where you ask questions that will trigger the patients and families to talk about the values and beliefs, understanding of their life events and actions of God, actions of the sacred, actions of the significant, so that they can share that with you. For example, you may ask, when life is hard, what do you use to cope with this? The second dimension is called relationships. Patients have need for relationships to connect with the community, to connect with family, to connect with others, to connect with their higher power, with the sacred or with nature, giving them a chance to say, how are you connected to others during this health crisis, for example, will reveal to you what the patients and families are looking for. Do you have support system from your faith community? Tell me about your experience with the healthcare team that we have here. These kind of questions will give you a chance, and you don't have to be a chaplain to ask these kind of questions. The third dimension from the SCI framework is called Transcendence and Peace, whereby patients and families experience the divine ability to have that centeredness and be aware in a way that helps them to increase peace and make sure that their distress is reduced or decreased. Are you at peace? How do you experience peace? Can you describe a time when you experienced peace? What was that like? So these are questions that anyone can ask as caregivers. The last dimension that you could also use is self-worth dimension, whereby you start asking the sense of belonging. Do you feel loved? Do you feel that people care about you? How are you taking care of yourself right now? How has this experience of illness or sterilization changed the way you feel about yourself? I share this framework to you all because you are not all chaplains, and maybe you are not trained as chaplains. We used this framework in asking some questions. The family, for example, the patients shared family was the most important. When we asked, what is the most important thing in your life? They shared some of these comments with us about how family is important to them. My grandchildren, my daughter, my husband, my little creatures, my friends, my church. And they even talked about on the earthly level how family is very important, but also how their family members make them smile and sometimes nervous when they are dealing with life crises. When they were asked whether they were religious or spiritual, some they said they were religious, and for them being religious meant they believed in God, and they also found that God loved them so much. When they were asked whether they were religious, spiritual, or both, those who shared that they were religious, they had something to share compared to those who said they were both. Those who say they were both, I do believe in God. I am probably more of a Christian and believe in something. And in that way, they felt like they have to share the connection that they have with their higher power and the connection they have with nature. How does this impact the family members and their illnesses? Cancer impacts family in many ways. They shared about how they tell them all the time. Those patients, they share with family members how they loved them all the time, what that love meant for family. Patients dealing with cancer, and especially when they are at the end of life, they had shared with us how close they became, talking about life, talking about history, talking about memories, talking about good things that have happened in their lives. During this time, if we remember very clearly what Dr. Balboni said, the healthcare system or the medical world finds a way of moving from treating a body, but treating a whole person, expressing how faith helps them, for example, is giving them a chance to talk about God gives us more than we can handle. A patient shares this. What does this mean to them? Maybe they see God as a powerful resource that helps them to cope. What about the impact of illness on their faith communities? They connected strongly with God. They felt like their God, their Jesus, their faith in God helped them to continue feeling meaningful in the life that they live. What about their coping strategies? What do they use? One patient expressed a conviction of acceptance, whereby once they have been overwhelmed by this illness and the prognosis of their illness, they felt scared, and they shared how they ended up accepting it. And when they accept it, probably they bring some solace and some peace that comes from their connection to the higher power. The others who felt scared. In fact, one patient said, I used to be scared of dying and everything, but now I am not scared of dying. I am scared of their children, them having to live without a mother at a young age. Sometimes what we think about patients and what they are worried about is not necessarily what it is. We may think they are scared about dying. Like this patient says, it's my family that I'm worried about. Others, they feel the reality, emotional response. One patient expressed acceptance of reality. It just causes you to accept the reality of what it is. At first, you think, well, you can beat it. But the more treatments you get and more things that go on, you kind of discover you really can't cure it. The patients, when they share this with you as a caregiver, how do you respond? The other patients who talk about, I am worried about what if I'm not here during this time? What do I do with my children that I'm leaving behind? All these emotional responses, they have something to do with the way we work with patients and families. I am so grateful for these two organizations that have come together to think about ways to create opportunity to talk about spiritual dimensions in cancer patients. The others question a lot about why me? Why did this happen to me? Like this patient says, I do question a lot. I've always tried, even thought I don't go to church or anything to live my life. But then I get this kind of illness. Why should I get this illness? Why me? The others who feel guilty through the process. They feel I am tired all the time, that I don't have the energy to do things like want to do them. So that makes me feel guilty. So friends, when thinking about the work that we are doing here at this conference, I wonder what goes on in all that we are talking about today. I want to spend some time here in this slide to challenge each one of us. To challenge you, you may not be trained as a chaplain, but you have what it takes to be present where patients and family members share their own distresses. And when they share, you don't have to speak the spiritual language. You may not have the spiritual or the religious language. When people say, what gives me meaning is my pet, for example, what do you do with that? If your setup is not conducive to bring the pet to these patients, and how do you work alongside to make sure that what the patient has shared is something that you can decide whether to refer the patient to the chaplain who will provide more resources and will provide the time that is needed so that the patient and the family can receive all that they are looking for. Cancer patients heavily, they rely on faith and spiritual practices in order to cope with the illness. I think at this moment you have discovered that the science behind it, spiritual, the faith has something to do with helping patients and families. Family and those who are very significant to the patient are most important. There are resources that need to be brought alongside so that they can work with them. Whether you are religious, spiritual, both religious, neither religious nor spiritual, all these have shown to rely on relationships, on family. So how do we make sure that family and the relations, significant relationships, are provided to these patients and families so that they can deal and cope with the illnesses that they are dealing with? There's also clear indication here that we have inadequate spiritual care, especially in cancer patients. So creating space for spiritual care to be available could provide some therapeutic resources to such a patients and families to help them heal and cope with their illnesses. Patients, especially those who consider themselves religious, have an expectation that you as staff members will be willing to open up and share your spiritual connections or your faith convictions. So if you are a nurse, you are a social worker, a chaplain, a doctor, and the patient is talking about something that is related to the Bible, and you know what that means in the Bible, they love it when you are able to open up and share what you think, what you know about that. They feel listened to and they feel identified with those who provide care. Patients who are identified as neither spiritual nor religious, they expressed a strong bond to family. And what that does for you is if family is more important to these people, if work that they do was important, but because of illness, they are not able to do that, or if giving and the philanthropy was a source of meaning, how do we create a platform or resource for these patients so that they can continue experiencing that which is meaningful to them? Again, let me recap by saying a question about, do you consider yourself spiritual, religious, both religious and spiritual, neither religious nor spiritual, is a very important question that you can ask. You don't have to be a chaplain. You don't have to be spiritual to ask that question. You just need to throw it out there. And if they say, I'm neither spiritual nor religious, clearly you will ask the second question that we had from the previous presentation. What gives you meaning and purpose at a time like this one? They will tell you what gives them meaning and purpose. And maybe from there, you may figure out whether you can provide what gives them meaning and purpose, or you can create space, or you can invite a specialist, a chaplain who is board certified, so that they can provide intentional long-term care that is needed. I want to conclude by saying there's still more work to be done. Educational advocacy, flexible interventions are needed so that they can help modify expectations in favor of spiritual care provision, especially in outpatient cancer patients or units. I am so thankful for the opportunity that I've been given. And I want to challenge each one of you, as you go, think of ways that you can integrate ways of making a difference in those patients and their families who every day continue to make a difference in their lives. Thank you so much.
Hi, everybody. I'm Stephanie Washburn with Living Beyond Breast Cancer. I'm really happy to be here with all of you today. I'm going to actually invite both Dr. Balboni and Reverend Dr. Maiko to stay on screen with us at this time. We have about 15 to 20 minutes for some questions and answers, and there are a number of really thoughtful questions coming in from our audience, which is no surprise. And I thank you for that very meaningful information that you just provided from the history and the use of art, and all the way up to the framework and really practical interventions that have just been shared. Just as a really quick reminder for people who are asking, we will be providing slides and the recording within about a week of the presentation via an email. The framework that Reverend Dr. Maiko just referenced in his presentation, you're going to actually have a link to those questions in an email that's going to come to you right as this program is ending in about a half an hour. So keep your eye out for those things. So I'm just going to jump right in with the questions from the audience. I think you'll be very interested to answer them because, again, they're pretty thought-provoking as well. So just to get us started, we have a question from an oncology social worker who, and we did talk about this, I think, some today, but I thought it was still really important to bring this back up for some distinctions. They say patients often distinguish between spirituality and religion. And going back to what Reverend Dr. Maiko was just saying, they'll say they're spiritual, but not religious. How do you define the difference and how relevant is that? So I think it might be interesting to hear from each of you about that. So Dr. Balboni, would you be willing to respond to that first?
No, it's a great question. I think at least the way that I conceptualize it, and I think frequently it's conceptualized in kind of the literature that I spoke to you all about earlier, is that spirituality is kind of the broader term, oftentimes defined as the way individuals seek meaning, purpose, value, connection. You know, we referred to all those themes previously, and religion is a related term that can be present, but not always. So religion is a shared practice, oftentimes with, you know, particular teachings, beliefs, practices that are shared by a community of persons. It's very important, particularly the community element is very important for certain people, but not all. Some people have a much more individual, a less traditional form of spirituality. Increasingly, that's the case, at least within the United States. Those that are unaffiliated has grown over time. It's now over 20% of the population. So it's a very important proportion of the patients that we're going to be seeing. But yeah, I think it's they're very much still related to one another. As Dr. Reverend Maiko mentioned, we need to be asking about both, but then understanding that they don't necessarily go together.
Great, thank you for that clarification. And is there anything else that you would add, Reverend Dr. Maiko?
No, I think Dr. Balboni, you have nailed it. That's how it is. When people say they are religious, they may have a clearly identified structure of rules and the space and the institutional alignment. When they talk about being spiritual, they may not have institutional prescription into that. They may be more of meaning and purpose and value and self-worth than institutional sacred books, reading all rules that bind them into that.
Great, thank you both so much. So going back to our audience questions, this is a very interesting one. How do you respond to patients who ask what your religious or faith tradition is? This question often makes me and other team members uncomfortable, and it feels like a boundary crossing. So again, Dr. Balboni, I'll start with you if you wouldn't mind sharing your thoughts on that.
You know, I tend, my rule in regard to patients is to be as honest as I possibly can be at all times, but then to always keep things patient-centered. I mean, I think you probably noticed in the questions we're giving you, this is about the patient and their care. So, you know, if someone asks me directly, I'll answer them honestly, but then immediately I want to turn it back to the patient because it's not about me, it's about them. And I want the focus to be on them, but certainly I'm willing and happy to share if I get asked. I haven't been asked all that frequently, but occasionally that's the case, particularly once I get to know someone better and they just want to know me a little bit better, they might ask me those questions.
Great, thanks so much.
I think that's very true. I'll try to be honest to them. I think sometimes patients, they ask that when they feel like they are being pressured by the way we respond to their spiritual needs. I think people are so scared about some religious behaviors and practices and beliefs, so they want to search and find out. But I think if they know that you are there and you are asking, you have good intentions, it is not going to work against you. Just to tell them the truth, I am a United Methodist, I am a pastor, and when I care for you, I don't care for you as a United Methodist, I care for you as a human being who has a mind, a body, and a soul. They will know that they will take advantage of that.
Great, thank you. That means a lot. I suspect that these answers are really, really helpful to the people who've posed them and probably others in our audience. Somebody else asked, do you have any recommendations on what to say to patients when they are having that why me moment, which I'm suspecting you may each hear that a lot. Why don't we start with you, Reverend Dr. Maiko, on that question?
And I think that's a very valid question. We have to celebrate it, and we have to thank them for asking that question rather than quickly judging them why they're asking that question. I think if they are told that, you know, this is a very difficult moment, I cannot even fathom, I cannot even imagine what you are going through. So you have all the rights of asking why me, and I may not have all the answers, and you may never even know the answers why you, but I'm glad that you are processing it at this moment. So I will not give them an answer. I will just celebrate them that they are processing. If they are calling God names or they are saying bad things about, I give them a chance so that they can, maybe this grieving process, giving them a chance to process it.
Thank you. Dr. Balboni, any additional thoughts there?
Yeah, I mean, very similar to what Reverend Maiko has said, just really, you know, first speaking to this, you know, this is such a terrible situation. I'm sorry that you're in this situation. I'd be asking the same question because honestly, I would. You know, and sometimes it's worthwhile to explore with them, you know, what have you thought anything about the answer to that question, or what are you thinking about that? Help me to understand that a little bit better. But I think accentuating that, you know, this is an injustice and it's terrible that this has happened, and just acknowledging that. And as Reverend Maiko has said, you know, saying to them, I appreciate that you would share that with me.
Thank you. So if you'll each bear with me just a moment, there are so many questions. I'm just going to, so if I look like I'm scrolling through, it's because I am doing just that and trying to hit as many as we can. We've got about 10 more minutes for questions, which is great. This is an interesting one, maybe building on something that was just discussed. You mentioned that a provider should open up about their religious belief and knowledge if they have some. But what is the best way for an agnostic provider to converse with a religious patient? Maybe we could start with you, Reverend Dr. Maiko.
So I think agnostic and atheist who is asking that question, we need to remember that they have a way of making meaning and purpose in life. Every human being has a way of making meaning and purpose in life. And if a question like that came up, is to make sure that we ask them to share with us how they value themselves and what life means to them. I think they will share, they may say they have a pet that gives them some meaning, or they have a forest where they connect with, and they're in the hospital, they can't go to the forest and experience nature's fulfillment. I think there's no spiritual, non-spiritual dimension that cannot be given a chance to be listened to. Every breathing human being has to be given a chance to be listened to and to be cared, and not to be put in a box of one way, but giving them a chance so that they can be experienced, that they are valued, who they are, and how they have shown up, and resource them where possible.
Thank you. And Dr. Balboni, how about a situation where it's a provider who is agnostic and they have a patient who is religious, and if that creates any discomfort for the provider, do you have any thoughts about how to respond in that situation?
I've certainly seen that, and I think that it's just as what was just said. Every person is spiritual in their own way, and it's just they happen to have their own. In fact, even someone from the same religious community there's going to be difference there. So just like there's difference, just you find your own form of meaning, purpose, value in something else, and they happen to have a religious tradition. So I think, just recognizing that in yourself, I think it is important we recognize our own spirituality, the ways in which we find meaning, purpose, value, nurture those. I think especially as we care for people that are dealing with tragic circumstances, it's really important to have those places of connection and refreshment for ourselves. And understanding there will always be difference. Again, even a fellow agnostic is going to have different ways of finding meaning, purpose, and value, but acknowledging it in the patient is part of patient-centered care. Just because I don't have the cancer that person has doesn't mean I can't relate to them, hear about their cancer, understand it, care for them within it. All that sort of thing. It's the nature of the relationship is there's all kinds of ways in which we are different from one another. But as we care for them as clinical caregivers, we ask, we learn, that we do that in all, whether it's the physical setting and even in the spiritual, that is the focus. Again, always being patient-centered. And just because we're different doesn't mean we can't explore and learn about them and support them in all of who they are.
Great. Thank you both for pointing out all of that interconnectedness in your responses. I'm going to go back to our questions here. This is really interesting as well. When working with a patient who is constantly stressed about finances, such as the expense of treatments or arrangements after they pass, what can I do, or what questions can I ask to help relieve that stress and bring that patient peace? How can I help connect their financial situation to spirituality and or their purpose?
That's a good question. The many traumatic experiences people experience might not be the illness. You are right. It might be finances. It might be marriage. It might be parenting. It may be losing a job. I think giving them a chance to continue sharing how these finances give them meaning and purpose will help to ask more questions, because sometimes the finances might not really be the one that is adding the stress, the trauma, but there are many other factors that will come from the patient and the family through that talking. The worst we can do is to start introducing spirituality to them, like, oh, God will provide. That doesn't help this person. You can't just tell, oh, a miracle is going to happen. Yeah, miracles happen, but that's a bad time to start introducing that until they start learning how money adds value to their existence and the future. And that's where specialist chaplains will spend more time to find out, why is this money the core driver of your trauma at this moment, and how do you turn it around to find something that is more valuable to you at this moment so you can focus on that, not to be stuck in the finances. And sometimes patients start with finances, but the more you talk with them, they may say, oh, it's not really finances, it's something else that is triggering this. And if this one is taken care of, the finances will not be an issue to deal with at this moment.
That's really helpful. Thank you very much. Dr. Balboni, is there anything you would like to add to that?
Yeah, no, I'll just add that I think one thing that came to my mind as Reverend Maiko was speaking is just that we need to understand where our limits are and where we need help. And that, so in a situation like that, when someone is faced with distress, clear distress, you want to, what your job then is to hear them, to listen, and then to recruit the resources that are available to them to try to help them in the best way you can. You need a team of people. It's not all on you. I think, with all of these things, we're, again, as I noted when I spoke, we're kind of opening a door and we're just saying we acknowledge this aspect of you. And there's some distance we can go, but we need to realize when, when it's well beyond us and it's time to call in the chaplain, it's time to call in a social worker, and it's time to try to enlist other resources or resources within the community in order to care for them well.
I like what you just said, Dr. Balboni, that chaplains, nurses, social workers, all interdisciplinary teams, they have to work together and they have to communicate so that they all know what is going on with this patient. The more they know from all corners, then they are able to address dimensions that will reduce, mitigate their traumatic experience.
Yeah, great points. And we have providers from so many different disciplines on this call today. I think that this probably resonates a lot with them, what you've just said. Thank you. Oh, very interesting. How would you handle a situation where the patient and family disagree over religion and spiritual preferences, especially in relation to treatment decisions? How about you, Dr. Balboni? Why don't we start with you on that one? It's a tough one.
Again, now, what is the generalist role? I mean, the generalist role is first to ask, and I'll just highlight that oftentimes so often what ends up happening is we don't even realize those dynamics are going on because no one actually asked. So just to name that, the question assumes that the generalist has asked and figured that out. And I think so often that conversation doesn't happen. So the first thing is that someone should be asking and understanding. And I think the role of the generalist not being trained is to know that this is well beyond my professional training. This is, I need to call in someone else. But what I can do is ask and also try to do my best in a patient-centered way to understand. So, help me to understand, to the patient who is kind of my center, right? The family is important, but the patient is my, a clear, second, but the patient is my central focus. Help me to understand this dynamic, help me to understand your beliefs, your family's belief, how that's interfacing, so I really hear it. So much of spiritual care is just listening, is caring enough to ask and listen. And then my talking with, if I'm with Reverend Maiko in the hospital, that's probably worth a conversation where I say, oh, this is the dynamic, and letting him know what I've heard, and could you help us and help this patient as they grapple with this issue. So yeah, I think that's definitely one where we're beyond what a generalist can do.
Great. Thank you for naming that and acknowledging that. I think that's helpful. And Reverend Dr. Maiko, what are your thoughts on that question?
I think, again, is talking, always doctors, nurses, chaplains, social workers, talking about what is going on is very critical. I can't overemphasize that. I think we need to remember the principles of ethics, and especially think about autonomy and justice. And when we think of the patient here, if the patient does not identify someone else to make a medical decision simply because they are incapacitated in some ways, then the patient is the one we need to focus on. So Dr. Balboni, you are right. We need to focus on the patient, and we have to make sure that the patient's needs are taken care of. I agree, there are some family members who would like to influence the decision the patient makes. But I think I'll stay with the patient until the patient tells me, now I've turned this over to the family and that they have signed the paperwork, then I start focusing on the family.
Okay, thank you. So I think we have time for about one more question. I just want to say this is one of those wonderful programs where our audience, even though we're not all in the same space together, becomes a really important part of the presentation by asking these very thoughtful questions. So I just want to acknowledge our audience today, as well as our amazing speakers. So let's see. Okay, why don't we end our question part with this? People have, and I think Reverend Dr. Maiko, you touched on guilt a little bit too when you were speaking earlier. People have often expressed guilt about their cancer, that they did something wrong that caused them to have the cancer, which is very painful. And how would you recommend responding? So how about if we start with you, Reverend Dr. Maiko?
The first thing I will ask, where did this come from? How did you come to this position of feeling guilt? And some people, they share stories. I know patients who have said, I smoked for a long time. I was told not to smoke. I feel guilty. And so when they say that, I'll just celebrate them. I say, I'm thankful that you have come to recognition, what has contributed into this. But I start helping them not to be stuck with guilt. And find ways of overcoming guilt processing. There are others who feel guilty because they did not come for screening early enough on time. And sometimes it's giving the patient a chance to grapple with guilt feelings, not to take it too quickly from them, but allowing them to process it to a point where they say, now I have accepted it. And that takes a long time.
Yeah, thank you. Dr. Balboni, is there anything you'd like to add to that?
Yeah, I'd say I love that, what Reverend Dr. Maiko has said. And in addition to that, I would say then going on to so I'm so inspired. I'm sure, all of us on this call have been inspired by the patients we care for. And typically it's saying, no, look at the ways that you have been so wonderful to your family, to your kids in the midst of this, and help them, to grapple with this really tough situation, and celebrating and naming the ways, in addition to giving them, the words that Reverend Maiko just shared with us, also kind of upholding them in the ways that they've really cared for others and done what is right and good in the midst of a tragic situation. I think that's a time to remind them of that and to really encourage and support them in that way.
Great. Thank you both so very much. So unfortunately, that is all the time we have for questions. We could probably spend the rest of the afternoon together if we could. So here is Elaine to wrap us up, and the rest of us can stay on screen while we close.
So on behalf of Living Beyond Breast Cancer and the Breast Cancer Resource Center, thank you, Dr. Balboni and Dr. Reverend Maiko, for sharing your expertise and valuable insights with us today. And I'd like to again recognize the Centers for Disease Control and Prevention for the support of this program. As a reminder, you will receive an evaluation link today. Please remember to complete it no later than October 7th. We'll also place the link in the chat for anyone who would like to do the evaluation now. For those of you who request contact hours, CEs, or a certificate of participation, you will be emailed your certificate by November 4th. We will also send a link to the program recording by the end of next week. Thank you for joining us today and for the care you provide to people affected by breast cancer. We hope you will participate in future educational programs. Please take good care and enjoy the rest of the day. This concludes today's program. You may connect at this time, and thank you for your participation.